So good morning, everyone. So I welcome everyone in this early morning session. And the speakers today, Professor Vimal Kumar Sharma. He's a professor of global health research in University of Manchester, UK. And he has been working on this global mental health assessment tool. He's working on it for more than 2 decades now. And his areas of interest are development of mental health assessment in primary care and specialist care, and early intervention in psychosis, self-harm and suicide, rural mental health and public health. And the tool has been now used in multiple languages in number of countries, and United Nations and Home Office of UK has taken that as their routine assessment method, and major research work of evaluation of early intervention in psychosis services of Eden and Super Eden and self-harm suicide Sashi project, published over 15 chapters in the books and over 80 papers in international journals. So thank you so much, Professor Vimal Sharma, for being here. So, and would you be presenting one after the other?
One after.
Yeah. Okay.
So he will do the first one.
Yeah. Okay.
So maybe you can introduce Mahesh Odiyoor.
Yeah.
So, don't know whether they have my CV.
Can I have the second CV? Professor Mahesh's CV also?
They don't. I don't think they will have it. All right. It's all right. I will introduce
Okay.
myself.
Okay then. Then Professor Vimal can introduce you. Then.
That's absolutely fine.
Good morning. I think we could have been in a small room or even in a corner in coffee area this morning because we didn't need this kind of hall. And in fact, I'm quite tempted for people to introduce themselves so that we know each other better. And I think my view is that even if we have one or two person who is interested in delivering mental health services, doing something for the community, and if we manage to influence them, then we have done our job. And I'm glad that besides our friends from Manchester University, Professor Catherine Robinson and Professor Lowpool from Bangor University, and now comes our main person, Professor Basu. I was just saying that we could have sat down in a corner of the room and had a more fruitful discussion. But any case, I think we will probably go through this, and I think we will make it more interactive rather than just one-way street. And I think this is probably a rehearsal for myself or other presentations. So one thing, especially, I don't really need to teach and preach our frontline honorable people, but a couple of people who are sitting behind. One thing we have to remember is that mental health is a dynamic process, and it ranges from being very productive to completely disabled. But you can move from one to the other direction at any stage. Therefore, never give up hope on people who have mental health problems. This is the key message. And nobody forever suffer from mental health problems forever. Even at the very right end, who's unfortunately in some countries, people are kept in a very unacceptable circumstances, in my view, chained, untreated. If you provide treatment, and especially if you provide a treatment early on, then that person could have been the great footballer. So the message is that if we identify these people, provide them support and help, then they can be extremely productive. The other thing one has to remember is that mental health and well-being obviously influenced by multitude of factors, and throughout the conference we had this theme that one has to have a holistic approach. So for example, physical health and intellectual abilities together, this is how we survive and live. But then we live in an environment, whether it's a physical environment, and obviously, if you live in a countryside with the beautiful trees and surrounding, you feel much happier than living in concrete jungle in cities where you don't see anybody and feel isolated. So social and physical environment, and then most of our awake life we spent at work, whether we are happy with our work, whether we are happy with people around us, whether we are happy with our seniors and juniors, that has a significant impact on our mental well-being. Needless to say about emotional environment, that's critical. But we shouldn't forget spiritual aspect as well. For some people, that is very, very important. And all the time, when we see people, we have to take account of all these factors to evaluate the well-being. I will probably chant the same slokas or probably sing from the same hymn sheet, which people have been singing in last 2 days here, mental health and public health. And I'm really grateful to Devbasis that he put this theme and brought at the forefront of people's mind that mental health has to be everybody's business. That is what mental health and public health means. And obviously, I was in United Nations IMO office, and they had boxes of with written sustainable goals, United Nations sustainable goals. And these were big boxes. And I was telling jokingly that will they stay in boxes or will they get out of these boxes at some point? Mental health and health equality is one of them. You have to remember that almost $1 trillion is the cost for anxiety and depressive disorders around the world. Suicide. And it's really sad to hear about these news almost on a daily basis. Students committing suicide in our central city in Kota almost, if not daily, every 2 or 3 days. If you look at the disability people live with, 1 in 5 years are lived with due to mental disorders. And then we also have to remember that mental disorders and physical disorders go hand in hand, whether it's a communicable disease or non-communicable disease. Obviously, again, repeating this, but sometimes we have to repeat ourselves to convince that, yes, we have to do something about treatment coverage, treatment gap, repeatedly pointed out in WHO reports that ranges from 50 to 80, 90% in some places. Specific populations, and we deal with refugee populations, international refugees. The prevalence of mental disorders are twice compared to what you see in population. And stress-related disorders are tenfold, which is understandable, the difficult circumstances they live in. And you have to actually see them, what conditions they live in, what kind of tortures they go through. Human rights. People still with mental disorders get discriminated. Even when we started pushing that mental health assessment should be part of health assessment for refugees who come to this country, people asked first question, are you doing this so that these people can be separated and not transported to these countries? We had to convince them that this is not the reason. The reason is that when they go to the countries where they settle, then we can set up adequate services for them. And people are still suspicious of why mental health being assessed. Finances, again, mental health is always not at the top of the priority compared to other sexy specialties in medical field. We have evidence-based treatment methods, but application in day-to-day practice is lacking. So for all these reasons, if you then look at the recent report produced by WHO, the Mental Health Report 2022, highlights again the importance of focus on improving mental health services in the communities. And they suggested different ways that you have to create a framework where you have strategies, plans, legislation, etc. You have to have will, not only from politicians, but community and public will to bring about the change in improving services. Obviously, without money, you can't really do that. So you have to have sufficient funding in order to provide these services, as well as support and sustain those services in communities. But lastly, which is probably in our view, and this is the whole presentation is about, competencies, that the health workforce competencies need to be enhanced. And I think along with, we have to empower people so that, in fact, I will go as far as to say that can we assist them in making their own assessments? And if they suspect that there is any difficulties, then they can seek for appropriate help. And obviously, how we restructure the services. Now, one of the things which sometimes irritates me, that great thinkers and genius people in mental health, they come up with brilliant ideas and they put these things in beautiful description how to deliver things. You know, for instance, of course, we have to deal with suicide and we have to do something about it. Of course, we have to reach out to people who have mental health problems. We know that the prevalence of mental disorder is quite significant. And I'll come to that in a minute. But how you do that, and then these highly intelligent people, they say, well, scale up for the common mental disorders, deinstitutionalize care for severe mental conditions, and then provide community. How you can do that? You provide community services. You introduce mental health and general health, and you go beyond health sector. We know all this, but I think we have to remind ourselves that these are important. How you can do that, but before that, in the Indian context, we have population about over 1.4 billion. This ratio of psychiatrists, mental health nurses, psychologists, social workers are compared to so-called developed countries is relatively, not relatively, significantly lower. So you have like less than a psychiatrist per 100,000 population. If you look at the UK, we have, I think, 1 in 10 or 15,000 if you look at the overall psychiatrist number. So that's the difference we are talking about. And we in the UK still complain. We go on strike is another issue, but we go on claiming that we don't have enough resources in the UK, in Australia, in America. America's mental health is even worse in that way, the service delivery. The issue here is that most psychiatrists, they tend to live in cities, and still our 65% population live in a rural area. And I, from WPA point of view, having some responsibility for rural mental health, it's very close to my heart, how we can reach out to people in remote and distant areas in rural communities. If you look at the National Mental Health Survey carried out in 2016 here, even if you take a very conservative estimate that at least 1 in 10% has significant clinical mental disorder. And the treatment gap, now I don't know what that means, but what it means is that almost 70% of people who have, if you call, clinical mental disorders, they don't receive treatment. In fact, I'll go as far as to say that those 30% receive treatment, 70% of them don't receive adequate evidence-based treatment. So the actual number of people who receive right kind of treatment, and I don't really want to go the kind of treatment provided to these people. But that's a probably controversial issue, and I'll leave at that. So what can we do? Obviously, one can argue that you enhance resources, increase capacity and competencies of frontline health workers. And the important thing is that we have to consider health as health, and mental health is an integral part of health. I can't understand, when you come for fever or chest pain or whatever, the doctor takes a history. How long this chest pain, you get chest pain more due to exertion, etc. Why can't we ask you, how do you feel? Do you worry about anything? How is your sleep? Do you get any unusual experiences? Simple things at the same time. And you can make a sort of complete assessment at that point in time. My view is that we have to think about that, and mental health training from medical students to nursing students and all healthcare professionals. We have to make, I think if I put forcefully mandatory, and their assessment even if they make cardiac assessment, unless mental health assessment is complete, they should consider that assessment incomplete. But that's taking too far. We have to go gently. The other thing which I think is the roles of specialists, we are focused on as service providers, treating individual patients. We have to think slightly differently. And I think our role, we have to change that in order to support frontline health workers, advising them, advising for management of conditions so they can manage. We are available as and when required. And it's, as I said, important to enhance public knowledge about mental disorders, and they could help them in identifying problems as well as identifying ways to help them. So I think with that background, I think I probably conveyed that one of the things we can do, certainly, is that we can equip frontline health workers in identifying problems with mental conditions. And I will hand over to our colleague, Professor Mahesh Odiyoor, who's been our colleague for a number of years. He is a very dynamic young psychiatrist, and his ability, he can make things happen even in the bureaucracy of NHS. And he has taken initiative in order to bring about changes in mental health services. In fact, he's strategic director for services in our NHS trust. But he specialized in developmental disorders, intellectual difficulties, and obviously is quite passionate that intellectual difficulties and neurodevelopmental disorders must be integral part of overall mental health delivery system. But I will hand over to Mahesh. He will take over. Thank you.
Thank you, Dr. Sharma, for that bigging me up in a way. I've been associated with GMHAT since my baby days as a psychiatrist. My first job was with Dr. Sharma in 2002, first psychiatry training job. And I've been associated with GMHAT since then. And it's now ingrained in my brain. I don't, even without thinking about GMHAT, I dream about GMHAT nowadays. So, and I think that's the case for most of the trainees who have gone through working with Dr. Sharma. That's what happens to them. Anyway, and they are not delusions. They're genuine thoughts. Right. So I think there is a very well-made case for a need for mental health training for frontline workers in the world. And this is not just what Dr. Sharma said. This is the theme of the last 2 days. And I think there have been very, very valid points made about mental health being a public health issue. The need for change is there. But all the time, the question is how. We have made a very good case about that it needs to change. And the next step is how do we do that? And there may be lots of practical solutions that people have, and GMHAT is one of those solutions and maybe a very helpful solution. So I'll just go through a few things as I present and probably give some time for a short video at the end, which is actually a video of an assessment being conducted. I would say there are two people who are, and I'll introduce them in the end. So the global mental health assessment tool, and there are versions of that. There are two main versions of that. There's a primary care version and a full version, but we are talking about the primary care version here. It's a clinical tool for the assessment of most mental disorders, and that's why it is important that when we started off, and when Dr. Sharma and colleagues started off with the thinking of the tool, the aim was that it has to be a tool which is simple to use, but also which will cover most of the mental disorders rather than specific tool for specific disorders. It can be used by healthcare and non-healthcare professionals. And that's the other important thing. If we have to make mental health assessment part of everybody's job, then we need to make it easy for people to assess mental health problems. And as Dr. Sharma said, it's very, when somebody comes with the physical health problems, why can't we ask a few questions about their mental well-being? Now, quite a lot of times they don't ask because they don't know what to ask, or they fear that if they ask, they don't know what to do about it. So if we make it easy for people, they might ask those questions more often, and hopefully they may address the needs more often as well. So that is the next step, which is aid for people to identify mental disorders and then refer or treat. And most importantly, the tool has to be quick, because if it's a very long tool, people are not going to use it. It has to be within that quickness, it has to be comprehensive as well, because otherwise we are going to miss out on quite common mental disorders if you focus on one or two. But most importantly, it has to be convenient, because in this world where everything is very quick and things are moving very fast, if it is not convenient, people are not going to use it. And if people don't use it, the tool might be absolutely brilliant, but it will be sat somewhere in somebody's desktop or computer or on their desk, and it won't be used. So those were the ambitions when the global mental health tool was designed and developed. So let us see whether we have achieved some of those. So quick. So the assessment, the global mental health assessment tool primary care version, takes about 15 to 20 minutes. That is for anybody. If I do an assessment on any of you here, or if you do my assessment, probably it will take that amount of time. Obviously, if I have more complex mental health needs, it may take a bit longer because I may have a few extra things to say. However, most of the primary mental health conditions, they may have one or two or three of those conditions, and that should take about 15, 20 minutes. So that 15, 20 minutes spending on assessing somebody's mental health, I think is, it's a reasonable ask. Within NHS, within the primary care service, in GP practices, the GPs have about 8 minutes per patient, 8 to 10 minutes. But even within that, we can then adapt and adopt this tool to be used in that primary care setting with use of other resources as well. It has to be comprehensive. So it covers all those areas that I've highlighted here, about 21 different areas. Now, we can make it, hundreds more, but those are probably the most common mental health conditions or associated symptoms. So if we cover them, I think we have covered quite a significant proportion of them. So we have achieved quick and comprehensive. And we have tested it out multiple times in multiple countries, in multiple languages, and it bears out. So, and I'll show some of those documents as well. Finally, it has to be convenient. So what is convenience now? I think yesterday when Mohan Nagashi sir presented, he talked about the sound and the word and everything coming together in a mobile phone. So everything now revolves on digital technology, on phones, maybe, particularly the phones, as they get cleverer and smarter. And with the advent of AI in future, probably the phone will tell us what to do as well. It has to be convenient. So this tool is free to use. Anybody of you can download it. You can go on the website, www.gmhat.org, and download it. Or there is an app version of it. You can go to GMHAT app and you can download it onto your phone. You can do it now if you want. I mean, it then asks for a username, but and it is easy to download, easy to use. It is translated to multiple languages around the world, 15 plus languages, most of the major languages. And so it can be used by any person in any country using any language. And if we need to convert them into more languages, it is quite easy to convert as well. And we have a methodology for making sure that it is done in an appropriate way. So there you go. It is quick, comprehensive, convenient. So do we have evidence for that? And I'll come to that in a minute, but a quick introduction to how it looks. So when we do an assessment, there has to be two elements. There is a qualitative element and there is a quantitative element, because we can ask stories from people, we can ask history, and we can talk for 2 hours. And then if we then don't have some recording of those symptoms, then it becomes meaningless, because then it's a story. It doesn't point out what the problems are. So within this tool, we are trying to incorporate both of that, both a qualitative element and quantitative element. So the beginning 1 or 2 parts, or the 1 or 2 slides of the GMHAT focus on getting a brief picture of what the problems are. And when we play the video, you will see how that plays up. So that should be fine. We just get a brief understanding of what the main issues are. And then I think it has also, we have added a couple of additional things as we have developed, because particularly in India and other countries, they said, we don't have any other screening for learning disability, sometimes no screening for epilepsy. So can you please add a couple of additional questions on that? So we included that as well, because if that's the bulk of problem and there is no other screening, let's do it here. So that's that. And then it goes through a series of questions in almost like a trunk and branch sort of system, where you ask one or two opening questions like we do in normal psychiatric or mental health assessment. You ask one or two questions. If those are positive, then more questions open up. If they are negative, you go on to the next section. So it is quite quick in that way, that you can move on through different slides as well. And then you rate them, and it's simple rating. Either you have a problem or you have no problem. If you have a problem, then do you have a mild, moderate, or a severe problem? And again, we try to, within the training, which I'll show a little bit later, we try to incorporate and help people to understand how do you rate that, because it's not very complex. And we do say, the tool is not your master. You are master of the tool. So use the tool as a framework to make your judgments, and then, help, make those judgments, but also make sure that you rate them, which helps us to understand what the problems are. Finally, you put your diagnosis. So it allows, it asks you to put your diagnosis. This is just a very, there are others, other sections to it, but this is just the last section of it where you put your diagnosis. But more importantly, when the report, so the other important thing is when you ask for a report at the end, the algorithm behind that takes all that information and then comes up with the report, which gives a bit of the qualitative stuff. So all the information that you have written down comes up in the beginning. So that gives a bit of the story. And then there are ratings, which then combine some of those answers that you're given, so that one, it gives you an understanding of the severity of the problem. Two, if you then use it as a follow-up tool, it gives you a very objective measure of whether things are improving or worsening, or whether they have remained the same. So again, it adds an amount of objectivity to your assessment rather than subjectivity. So it's not your gut instinct saying that the person has improved. You have evidence, but also that can then help you talk to the families, the patients, and so on, to say objectively where things are improving. More importantly, the tool also takes the information and gives some suggestions of possible diagnosis as well. So the algorithm helps you with that. So if we are looking at frontline staff who may not have done mental health assessment, if you train them to at least listen to the story and make a rating, then what it does is it uses the ICD-10 criteria, and then gives a suggested diagnosis as well. So it helps people make decisions. And sometimes that decision, people can go into decision paralysis because they gather all the information and then they say, we don't know what to do. So what is the problem here? So what it does is helps people move on to that next stage, where based on that, you can then take a decision using the care pathway, which is also built into the GMHAT, to say what next. So it gives some principles, general principles of what the issue, what are the treatment options available, but also it gives you indications of what the possible treatments are. So if you have made a diagnosis, or GMHAT comes up with the diagnosis, say it's depression. So you then click on there is some principles, so you can look through the principles, but then if you click on the depression section, it says what are the potential things that you may want to consider. Either you can do it yourself, or you may refer to somebody else. So again, it helps people. It's an aid to people to help people who have mental disorder or mental distress. So as you can see, it is trying to make the process of mental health assessment as simple as possible for frontline staff and specialist staff. So evidence, because every time you talk about things, academicians, clinicians, all of them say, oh, so what's the evidence for that? We all like to know our evidence. So there are multiple field studies in multiple languages using GMHAT PC. So some of the examples are there in English, in Spanish, in Arabic, in Hindi, in Dutch, in Marathi, all different languages, and done by all different types of frontline staff. So GPs, practice nurses, psychologists, nurses, newly qualified doctors, and later on we'll show non-medical and non-clinical staff who have done assessments using GMHAT as well. And when you aggregate the total of all those different papers put together, and that's quite a lot of evidence, the kappa, the sensitivity, specificity of the tool, stands against any other tool in the world that is used for mental health assessment. It has good sensitivity, it has good specificity, and it has good inter-rater reliability. So it's an excellent tool based on all that. I'm not saying that, Dr. Sharma, we may be extremely biased, and I will say it's the best tool in the world. However, it is what the evidence says as well, that it is a very useful tool in the collection of other useful tools, but this is a practical tool that can be used. I think I've said enough on that, but here are all the different papers. So there are more than 12, 15 papers on GMHAT primary care itself. And these are some examples of all those papers written on the tool from various countries, from Colombia, from India, from European countries, and so on. Then we had the refugee crisis is a major problem, migration and refugee crisis. So this was pre-COVID, when the Syrian refugee crisis was quite significant. The Home Office in UK said they wanted an easy tool to assess some of the mental health needs of the refugee population. So global mental health assessment tool was suggested, and they used that as a initial trial. So the Arabic version of the global mental health tool was used as an assessment tool in the Syrian refugee population. And there is a report, and this is online in the Home Office website, and this is part of that. It shows that there is very clear evidence for the use of global mental health assessment tool. And on the basis of that, they have now asked us to continue to provide training for the frontline staff to do assessment of refugee population who are coming into UK. But IOM are considering that they would want this as a tool for all their refugee resettlement programs. So that's the next stage of development on that. And they found that the ease of use, but also the fact that it can be used in multiple languages, is something that they would find it very, very helpful. And as Dr. Sharma said, the mental health burden in this population is significantly high. And if we don't assess and don't manage that early on, the problem will become a major problem and a long-term problem, and impact not just on their generation, but on future generations as well. So it's an important tool to help with that process. So we talked about the tool, but then there is a need for training. So if you are asking that frontline staff use the tool, then there needs to be a good comprehensive training for that. Now, when we talk about training, people think of, is it months, is it years? How long does it take to do a good mental health assessment, and so on? And what we have tried is, we have tried a few models, and we have come to a really good understanding of what training could take place. So we have done it in two ways. One was over a period of time, over a month, but split it into twice a week, 2 hours every week, so that it fits in with people's time. Because we know people are busy and they may not be able to take time off from work. However, then when we did the training for the Home Office staff, we compressed that into 2 days. And both those models work really well. So we could do it over 2 days intensively, or over a period of time in small bursts to help people to complete that training. So overall, it helps, it works. And the main things that we do is, in a simple term, what to ask, how to ask, and how to interpret what you have asked. So 3 simple things. And so what to ask gives a knowledge of mental disorders, a brief understanding of what those disorders are. How to ask gives you a competence in the interview of using the tool, but also in communication skills. Some of the things that we take for granted, but we do emphasize some of those simple things of empathizing and working with other people. And the final one is how to interpret, gives you competence in using the tool, but also, as I said, when it comes up with conditions, diagnosis, and so on, how then can you use the pathways in order to support people to navigate through their needs as well. So the training package, as I said, it is in two ways. It's either 8 sessions, 2 hours per session, or we compress that into 2 days. And sometimes, if it is really frontline staff who have never done any sort of clinical this thing, we could add another additional day just to give them a broader understanding of health, not just mental health, but general health as well. So there are ways that we can incorporate that. And it can be used, and currently, all the training that we have done, there has been a range of health professionals who have gone through the training. It's not just for mental health staff. It can be used by anybody. And the sessions will contain a lot of different things: interactive training, some video assessments, video interviews that we have recorded, role plays, And then in the longer version, as in over the 8-session period, what we also do is ask people to go and do assessments of their own and bring back their learning to discuss in the next session. So again, it's almost coaching as well as we go, rather than just imparting education. So there are ways that it can be used in multiple settings. So some examples. So this was an ICMR funded project in Alwar in Rajasthan in 2017-18. So this was training and support. And as you can see, Rob and Kat who are sat in the front were in that training. So these were the young days, Rob and Kat. Those were the days. So and then Dr. Sharma is on the floor, much more sprightly than everybody else. So this was with ANMs, frontline staff trained to use GMHAT, and they have used that and they have shown, and this is using tablets, phones. So you can use it in the most remotest of place where there is, where there's limited limited internet facilities or limited electricity, whatever that the condition is, it can be used in any place. And that's the whole point of it. It need not be a paper and pen exercise. It can be done in electronic tools. So which means that easy for recording, easy for downloading, easy for using, easy for sharing with, specialist staff who may then be able to use that information to interpret and support. So it makes the whole process extremely convenient. This then was our next stage of training. This was our COVID era. So, suddenly we had to go into, until then it was quite a lot of face-to-face training. Suddenly we went into digital training. And this was a training that we do through IHMR, in Indian Institute of Health Management and Research in Jaipur. And this was our first session. And then we had participants from Myanmar, from Bhutan, from Nepal, as well as India. And the feedback was very, very positive. In fact, the staff that came from Bhutan and Nepal have been having conversations with their health departments to see whether GMHAT can be part of their health programs as well in the country. So again, it has had a significant impact. So again, that was a different version of training that we offered. Finally, the more recent one, where the tool has now been adapted by IOM, the largest sort of department within UN, where migration, in terms of it is an international organization of migration. So they asked us to provide treatment, and Dr. Sharma has been to a couple of places, and a colleague of mine has been to another country. So this was the first one that we did in Kenya. That was earlier this year, followed by a training in Pakistan, which was done by one of our colleagues with Dr. Sharma in the background. And this was last week in Jordan. And in Jordan, we had people from some of the neighboring countries. And as you can see, if you look at it, those are the 3 significant hotspots for migration, Africa, Pakistan, Afghanistan, and Middle East. And that's where the training went. And we have had more than 90 participants in the training so far. Feedback has been absolutely positive, which is, again, for us, the use of the tool has, as I said, it has to go back to those 3 principles: quick, convenient, and comprehensive. And the feedback so far has been that it ticks all those boxes. And if that happens, then I think it will be used more often. So we just want to show a small video of an interview. And these are 2 clinicians who are frontline clinicians. They are not psychiatrists.
Hi, come in. Come sit. I'm Natalie. Hi.
Nice to meet you.
So thank you for coming. I'm going to be using a tablet today to guide me through the questions. Is that okay with you?
Yeah, it's fine.
Okay. So don't be concerned if things sometimes come across as a little bit odd when I'm asking questions. Some of them won't apply to you, but we have to ask everybody the same sort of questions. Okay. You all right to start?
Yes.
So how have you been recently?
I've been feeling a bit low recently. And a bit low energy.
Okay. So do you have any problems?
So I've been feeling just generally a little bit sad. So I've not got that much energy. I'm not sleeping that well.
Okay.
And as on the day, I'm feeling very tired all the time.
Right. Okay. So when did all this begin?
About a few months ago.
Okay. And has it been consistent for those few months?
No, it varies. But probably consistently over the past few months.
Okay.
Generally.
Okay. So have you had any problems with your mental health in the past?
Not really. I've suffered a little bit from anxiety in the past, but nothing like this before.
Okay. And can you tell me about your family? Is there any problems with mental health in your family?
Not that I know of. I don't really talk about that much. But not that I know of.
Okay. So who have you got in your family?
So I live with my mum, my dad, and my brother.
Okay. Okay. So is there anything about your personal or your social life that you find distressing?
So I broke up with my boyfriend a few months ago. So I think that's what maybe was when it all started.
Okay. And have you got any problems in sort of the area of work or housing or finances?
No, not really.
Okay. All right. And have you ever suffered from any sort of trauma or abuse? And by that, really, I mean physical trauma in terms of a big accident or sexual or emotional abuse, neglect?
No, never.
Okay. All right. Have you ever suffered from fits or epilepsy?
No.
Okay. And can you tell me a little bit about your development as a child? Were there any problems with your early milestones, like speaking or walking, anything like that?
I had to have a speech and language therapist when I was
Okay.
younger. That lasted until I was maybe 6. But then I went back into regular primary school.
Okay. Okay. Do you remember what you would do with the speech therapist?
No, it was too young.
Okay. All right. And how was school in general after that?
Yeah, it was fine. I never did that well, but I managed and graduated.
Okay.
And yeah,
So what do you mean you never did that well? What happened?
I always struggled with exams in school.
Mm-hmm.
I never really enjoyed it that much.
Okay.
I always enjoyed the social aspect of school more than the educational side.
Okay. But you said you graduated.
Yeah.
Okay. So did you get your GCSEs and
Yeah,
any other qualifications?
A levels,
Okay.
but that's it.
Sure. Okay. So go back to the worries that you talked about before. Do you worry a lot?
Yeah. So like I said, I've suffered from anxiety
Mm-hmm.
for the past few years, maybe. And that's normally when something's big is happening. So if I'm moving home or going away or something, I worry about that quite a bit.
So how much do you worry about these things? Is it something that passes by you quite quickly? Does it keep you awake at night?
It lasts for a couple of weeks.
Okay.
It keeps me awake at night. I don't want to eat during that time.
Okay.
And it just takes over my life, really, for those 2 weeks.
Right. Okay. So is that impacted on work?
Not so much work. I just try to live with it for the 2
Right.
weeks. I haven't really developed any coping mechanisms.
Okay. Do you ever get frightened or nervous?
No, not really.
Okay. How's your concentration?
So the reason I finished over there was I wanted a few minutes for any questions as well. However, that just gives you, a flavor of what so the first few questions were very much open-ended questions asking about how the person was. And the person asking the question is a speech and language therapist. She has never done GMHAT before the video. So she had not seen the GMHAT. She has not used the GMHAT. We brought them on the day for doing a video, just 5 minutes, just talking through the tool. And then she started the assessment. And the girl, she's one of our research assistants. Again, she had never seen a GMHAT before, never done the GMHAT before. And we just said, just be yourself, talk it through and see how it goes. And so these, yes, the person was not a real patient. However, the person assessing is not one of our standard frontline mental health practitioners who would use that sort of a tool either. So it can be done very easily and very quickly. That's what we want to demonstrate here. And as you can see, the questions were it flows naturally into the way of history taking and assessment that we would do. So the second part where she was asking, or the next questions where she was asking about anxiety and so on, were the scoring questions. And what we try to say is that there is a few questions as a framework, but you don't need to just stick to those questions. It gives you a framework. You can then use your own initiative to ask a few more questions as in how you think suitable before you make a judgment of how severe the condition is. So it is about using your judgment. And as I said in the beginning, the tool is not a master. You are master of the tool, but the tool gives you a framework to ask the right questions, get the information, make a judgment, and then hopefully offer better help and better care for the people. I'll stop there and take any questions. Thank you.